So it's a 40-year-old female indeed, referred to as by another gastroenterologist. She had since 1 or 2 years predominantly dysphagia and developed as well regurgitation. Her ECHO score, sorry, typo, quite high, 3.121. Then she had the workup, a barium swallow, where you can see, well, it's not that extensive, but then again, it's not the highest resolution investigation. The upper GI, apologies, no pictures, but the less was described, the lower esophageal sphincter was described as being tight. So she has a manometry, IRP is increased, 22.6. All swallows had failed peristalsis, and she had pressurization, pan-esophageal pressurization in 70%. So the conclusion was
looks nicely like the one we showed before for type 2 achalasia. So perfect.
So that's type 2, and that's case 2.
Mag de licht in de zaal een beetje minder alsjeblieft. So we're going to talk about the findings at gastroscopy of achalasia. So often there's a lot of bubbles and slime in the esophagus. That's number one. And you see that here. Often there is food residue in the esophagus. You see that as the disease progresses. Here we don't see that really. But slime and saliva we did see. So that's a clue. And then we're now at 30. We're coming down. There's lots of contractility. And now I'm pushing onto 35. You can see the esophagus is resisting me. And as I'm going down, and I've got a tunneling cap on as well, so that's going to make it easier to pass. So yeah, even with the eye of faith, you can see that there is some spastic component to the distal esophagus. And then finally, when you retroflex, you should not see any sort of hernia, and the junction should be really gripping the scope, which it clearly is here. So those, I think, are the components. And if someone's referring a patient for achalasia or discussion of a movement disorder, then I want to see this view. Because if you see any kind of hernia there, then you know that the patient doesn't have achalasia. So please close, explain what you mean by
when you have the scope in a relaxed position, that means it's not pushing it against anything. You can reliably take your measurements, and that's what we do when we check for where the LES is. But when you're in a tunnel and you're really pushing in, that measurement can change a little bit. It will not change by 5 centimeters, but maybe 1 or 2. So it is an indication of where you are, but it is not reliable if you want it.
So how can you minimize? How can you minimize that? Please think about that and don't answer it yet, because there's an interesting finding here. So here you have the muscle starting to split, right? The plane is where the knife is now. So it's not so easy here, and I'm just making sure that I am doing the right plane here. So the muscle is kind of, I think we're just across the junction now, actually, because actually here's the stomach, right? For sure, that's the stomach. We're turning a little corner here, so we have to go around there, and the muscles become a lot thinner. Close. We've still got a bit of some sort of musculature hanging around at the back there. So I want to take that out if we can. So we can put some blue in between here and there. Open. Try not to injure that blood vessel. And then just take a little cut down here, maybe. That's it. Okay, so that's re-entered that plane quite nicely. Close. We need to get the knife up here to re-establish this plane here. Okay, so that's looking all right there. And then I want to come just around this corner and take the rest of the muscle out like that. Open. this often happens at once you're in the stomach, that the muscle just falls apart. And I think we have gone quite far down into the stomach. Would you agree with that, Kevin? Close?
Yeah, well, I think you have, yes.
So probably further than I needed to. And that's why this muscle is now becoming all sorts of directions, all sorts of angles. I'm not sure that, I mean, I will complete this down here just to show you the principle, but I'm not sure that it's entirely necessary for this procedure. Open. So let's just now check our tunnel for things we wouldn't like to see, like bleeding. Again, you can apply, well, if you see bleeding, treat it. So here, for example, and then I would, in general, apply the water technique to checking whether there's bleeding. So we need the water pedal, and then just put water in the tunnel. Not too much, just enough to see whether you think there's bleeding or not.
And the principle is if it stays clear, it's fine.